Okay, start. Okay, so welcome to the 20th session of this series. And today, dependent on the sort of popular request, wanted the tumors to be, thanks for that. Right. Wanted to do the tumors. So we'll start off with endometrial carcinoma. Okay. So as it means, endometrial carcinoma is the malignancy of the uterine endometrium. Okay, and so what we have to remember is initially, right, is that before we go on to other things, there are mainly two types of endometrial carcinoma. The type 1 are the ones that arise or start off when there is hyperplasia or an increased thickness of the endometrium inside the uterus. So you have a very thick endometrium, and in that base we have a carcinoma, and usually it is a endometrioid type endometrial carcinoma, right? Do you understand? So this arises mainly due to the hyperstimulation of the endometrium by estrogens. So whenever there is a place where there is an increased production of estrogen and unopposed estrogen stimulation of the endometrium can become overstimulated, it becomes thick, and it becomes a cancer. And these are what we call endometrioid type endometrial carcinoma. Okay. Then there's another type that is not related to estrogen, and those are not very good types, where a lot of things or these cancers or these malignancies rise or come up when the endometrium is atrophic, right? So they come on the base where the endometrium is atrophic. There is no endometrial stimulation, right? However, the cancer is there. So what are these? These are the other types of cancers. Clear cell, then there is serous papillary, then there is squamous cell, then there is undifferentiated, then there is maybe metastatic cancers, right? All these types, right, they rise or come up in an endometrium which is atrophic. These are what we sometimes call type 2 endometrial carcinomas. Do you all understand? So do not think that all endometrial carcinomas, which is sometimes a common misconception, that they arise, right, on the basis of a thickened endometrium. No, the type 1 ones, they do, right? While the type 2 ones, they don't. You have an atrophic or a non-estrogen stimulated endometrium. Is that clear, children? So these are the two things. Now, so since we have these two types, you have to remember, right? Of these two, the one that behave relatively better are the endometrioid type ones, right? While those that behave more aggressively, gives more metastasis, and sometimes the prognosis is relatively poor, and they do not behave very well, in the sense, right, as far as survival is concerned, are the type 2 ones, right? So there is something generally that all of you all must understand about endometrial carcinomas, right? Okay, so let's look at this. Overall, almost all, the majority of the carcinomas are endometrioid type. Luckily, the the other types are less, right? And therefore, overall, the survival rates are good. Overall, the prognosis is relatively good, right? And therefore, endometrioid or endometrial carcinoma is something that is most of the time discovered early relative to the other malignancies that we look at. And why is this? Because what they do is that they have bleeding. Okay. And if you look at all endometrial carcinomas, the chances of a woman having an endometrial carcinoma, right, even if she presents with irregular bleeding, right, when they are less than 40 years of age, the chances are very small, less than 2%. Okay, so almost all endometrial carcinomas or malignancies, only 2% of them will present, or we will discover them when the age is less than 40. The rest of the 98% will be after 40 years of age. So the commonest age group to have endometrial carcinoma is from about 40 onwards. So 40 to 55 is the age where different types of estrogen stimulation can occur, either due to the fact that they develop obesity or maybe medication, right? They develop other types of cancers, maybe like, and they are given tamoxifen or medication that stimulates the endometrium. So 40 to 55 is the age group that these endometrial carcinomas are common. After about 55, okay, they can develop up to about 60, 75 years of age or so. But then the types starts to vary. You get more type 2 endometrial carcinomas towards 60s, 65, 70s. So if a woman presents to you with features of bleeding, or we discover an endometrial carcinoma at say 70 years of age, we may be looking at something which is not endometrioid, but different ones. Maybe clear cells, maybe serous, right? Those are not, they do not behave very well, and the cure and the prognosis may be worse than the normal endometrioid carcinomas which we meet at a young age. Do you all understand the age sort of difference and group? Yeah, right. So now if you look at all this together, now let's look at the type 1s, which is the majority, and think about the risk factors. Now, as you all understand, okay, all these risk factors are connected to what? Estrogen hyperstimulation. Okay, so most of these risk factors or causative factors are connected to usually connected to when there is an excessive production of estrogen. So what is the first thing? The first thing is obesity, right? And why do obese women produce extra estrogen? Is because in their fat tissues, in their peripheral tissues, androgens are converted by the enzyme aromatase into estrogen, right? So excessive fat, right, will cause an excess of estrogen, and therefore overweight obese women will have an excess of estrogen being produced in the peripheral tissue. That will cause, so therefore obese women have a higher incidence of endometrial carcinoma. Do you all understand? So endometrial obesity becomes a risk factor for women. That is number 1. Okay. Then any woman who is on tamoxifen therapy, right? For what? Tamoxifen is given when a woman is found to have breast carcinoma or estrogen receptor positive breast carcinoma, okay? And when that cancer is taken off and the breast is taken off, to prevent breast cancer in the other breast, or to prevent the recurrence of breast cancer, tamoxifen is used, right? Now, what is tamoxifen? It's an estrogen antagonist, okay? It antagonizes estrogen in the breast. So these are called SERMs, selective estrogen receptor modulators, right? And what does that mean? That means when you give these medication like tamoxifen, raloxifene, anastrozole, this when you give, they have different actions on different receptors in different organs, okay? So what does tamoxifen do? In the breast or in the remaining breast, it suppresses or antagonizes the estrogen receptor. So it blocks the estrogen receptor. So it prevents, to a significant effect, the recurrence of estrogen receptor positive breast cancers in the remaining breast. Do you all understand? That is well. However, the problem is tamoxifen acts differently because it's a SERM, right, on other estrogen receptors. And what it does is it stimulates the estrogen receptors in the endometrium. And it stimulates the estrogen receptors in the bone as well. In the bone, it's beneficial, okay, because the bone density increases. But in the endometrium, it increases the thickness. And therefore, tamoxifen, or women who are on long-term tamoxifen for the prevention of breast cancer, has an increased incidence of endometrial cancer, right? To counteract, sometimes, if the woman does not have a uterus, then fine. But sometimes to counteract that, sometimes we have to give progestogens into the uterus itself, like in a Mirena, right, to prevent them developing endometrial carcinoma on women with when they are on tamoxifen. There are several trials trying other SERMs for the prevention of breast cancer, and anastrozole is one of them, right? It's a SERM. It also antagonizes the same way as tamoxifen the estrogen receptors in the breast, right? And at the same time, however, it also antagonizes the estrogen receptors in the endometrium as well. So probably it might be a better sort of medication. So the trials are going on. So therefore, there are women who may be on anastrozole, there are women who might be on tamoxifen. But what the end result means, if a woman is on any type of medication for the prevention of breast cancer, then the monitoring of the endometrium or the endometrial thickness becomes a routine practice. So therefore, when a woman comes to you and say, okay, I am 55 years of age or 60 years of age, okay, I'm postmenopausal, whatever. And she says at the moment when you take the drug, she says she's on some form of SERM, selective estrogen receptor modulator, or an estrogen antagonist, right, to prevent breast cancer. Remember, endometrial cancer is a possibility. Is that clear? So the second risk factor is tamoxifen, right? Third one, if you look at the whole thing, polycystic ovarian syndrome, right? And what does polycystic ovarian syndrome does? It increases or produces a continuous amount of, you have a continuous amount of increased estrogen. So there are lots and lots and lots and lots of follicles, okay? That's why they're called polycystic ovarian. I think we did a class on that. And therefore, all these, right, they do not ovulate. Now, antagonization of estrogen is done by the progesterones. And progesterones are produced by the corpus luteum. And the corpus luteum is formed only after ovulation. So there must be ovulation for progesterone production, right? So if there is polycystic ovarian syndrome, what happens is all the follicles produce estrogen. However, they do not, there is no ovulation, right? Or there is a rare ovulation, and therefore the antagonization with progesterone is not there, and therefore women with polycystic ovarian syndrome is at a higher risk of having endometrial carcinoma. Okay, so that is the third risk factor, right? The fourth one, if the women are on estrogen replacement therapy, right, of any sort, and usually not combined, but estrogen therapy alone, right? So estrogen can be given for various reasons. For example, women might take it for menopausal symptoms, right? Women might take it for bleeding problems, right? So if, however, if no progesterone is given to counteract its effects, estrogen therapy or estrogen therapy alone can make the woman have increased risk of endometrial carcinoma type 1. Okay, is that clear, children? So hormone replacement therapy in any form, therapy for postmenopausal symptoms, right? Therapy for any other thing, if it is estrogen alone and you do not antagonize it with progesterone, then that can cause, it becomes a risk factor for endometrial carcinoma, right? Is that clear? So the next risk factor in the history is if a woman has early menarche or late menopause. What does that mean? The earlier they have menarche, then there is the ovaries start to produce estrogen. Okay, and then that causes the woman to have a higher level of estrogen from very early. And if it is post, if the woman continues to have estrogen production for a long time, right, and it's a late menopause, the endometrium is subject to estrogen stimulation for a longer period of time. And therefore, these women also may have an increased risk of endometrial carcinoma. Is that clear, children? Right. And of course, what are the preventive things? So any progesterone therapy is preventive. Pregnancies are preventive because there is no estrogen, excessive estrogen production, right? If the woman is, or if the woman is, the womb has been taken off, hysterectomy, of course, there won't be any endometrial carcinoma, right? If the woman is on a Mirena coil where there is progesterone inside the cavity, then the woman gets protected from endometrial carcinoma, right? If they breastfeed for a longer period of time, there is no stimulation, sometimes it may be protected. Then if the woman is on oral contraceptive pills, but combined oral contraceptive pills, right, for a long time, what happens is the amount of estrogen is very low in those pills, and there is also progesterone, then it becomes protective, right? So all these are protective factors, but initially remember the chances I have told you what makes the risk higher, all right, is with what we just discussed. Okay. One other thing, there's an increased risk of endometrial carcinoma when it is familial. When there is a familial Lynch 2 syndrome. What does that mean? And these are the ones where we meet endometrial carcinomas and different other types of carcinomas, right, like type 2, before 45 years of age, sometimes even less than 5. So if you meet different types of endometrial carcinomas, right, before 45 years of age, at a young age, there's a possibility it may be a familial syndrome. And what is this? It's called Lynch 2 or what? Non-polyposis colorectal malignancies, right? So these are what? there is an associated, these syndromes are, or the genetic predisposition for different types of tumors, right? And they have colorectal cancer without polyps, right? Non-polyposis, colorectal cancers. It's associated with endometrial cancers as well, okay? There may be ovarian cancers associated. There may be brain cancers. There may be skin cancers, right? There may be small bowel cancers, and there may be pancreatic cancers. Skin, brain, pancreas, small bowel, large bowel, ovarian, and uterine. Okay, so these are the 7 which I remember. There are other things, but these are the main 7 which you remember, which is associated with Lynch type, Lynch 2 syndrome, or hereditary non-polyposis colorectal cancer, HNPCC. Is that clear, children? So there is also a risk factor for cancers, which endometrial cancers, which come when you find them at a young age, less than 45 years of age. Okay. So these are the general information that you need to understand about cancers, endometrial cancers. Now, if you look at these cancers, and if you look at the blood sample of the uterus itself, okay, we will understand exactly where it spreads to. See, the fundus of the uterus at the top connects the ovaries. There is the tube, there is the ovarian ligament and the ovaries, right? And then you have the round ligaments. Now the ovary derives its blood supply from the aorta, okay, through the infundibulopelvic ligament. And so the uterine blood vessels have an anastomosis with the ovarian blood vessels through the ovarian ligament. Okay, so if there's a cancer involving the top, there is a possibility that the metastasis will travel along the infundibular vein, and the first lymph nodes which they did are where? In the para-aortic lymph nodes. Okay, so the higher the tumor grade, the more malignant it is, the higher the myometrial invasion, right, and higher the stage of the cancer, right, the higher the chances that the para-aortic lymph nodes may be involved, right? For example, in stage 3, sometimes up to about 22% may be involved. The para-aortic lymph nodes may be involved, right? So up to what? Up to the renal vein. So they travel up right up to the renal vein. So up to the renal vein, the para-aortic lymph nodes may be involved. But that means that it has spread more than usual. Okay. The uterine artery comes from the anterior division of the internal iliac. Remember, you have the common iliac, right? You have the aorta, then you have the common iliacs, and the common iliacs divide into the external and the internal iliacs, right, children? And the internal iliac comes down, and there is a posterior branch and an anterior branch. Okay, from the anterior branch, the uterine artery goes or divides down and comes onto the uterus, right? So the venous supply is also the other way around. So the lymphs collected from the rest of the body, right, the rest of the body of the uterus will come along these and spread along the lymphatics of the internal, external, and the common iliacs, right? And because the obturator lymph nodes are also close, right, and there is a blood supply that connects these as well, so therefore they will also go along to the obturator nodes. You understand? So usually the immediate lymph node or invasion or the metastasis to the lymph nodes or the lymph node involved will go into what? Not normally to the para-aortics, but usually to the internal, external, common iliacs, and then to the obturator nodes. Is that clear, children? Right? So you have to understand the blood supply and the venous drainage and the lymphatic supply to find out exactly where they are going. If the cancer goes into the uterine cervix and to the top of the vagina, okay, what are we talking about? We are talking about stages which are greater than 2, okay, right, which we'll discuss in a minute. Then, of course, these through this, they can go into the inguinal lymph nodes. They can go into the inguinal lymph nodes. They can go to other places. They can have distance metastasis. There can be lung mets. Okay, so there can be cervical, right? So all these the claviculars, right? So they can spread further. Do you understand? So therefore, if the if it invades into the cervix and then spreads out more, then other inguinal lymph nodes also can be involved in the whole process. You all understand? And of course, if it's then becomes more and more, then metastasis can be found in almost every organ. But commonly, they go to the lung, okay, from the endometrial carcinoma. Clear how it spreads, children? Right. Now, let's look at what makes or how do we, what are things that we look for when we are talking about how bad it is, or how do you do? What are the things that we are going to look for, or what information is going to tell us what stage or what the prognosis is? There are few main things that we always look at when we think about how what the prognosis is going to be. Okay, obviously the first thing that should come into the mind, the higher the stage, right, stage 1, stage 2, stage 3, stage 4, the higher the stage of the disease, right, the worse the prognosis is going to be. Stage 1 disease, which means confined to the uterine corpus, okay, only in the uterine, only in the uterus, okay, uterine corpus, that is stage 1. The 5-year survival rate is 85 to 90%. You'll understand? Stage 2 would mean what? It spreads to the cervix, okay. So there, the survival rate drops to about 65, 5-year survival rate. Okay. Then stage 3 would mean what? It has spread slowly, maybe onto the top of the vagina, right? Maybe onto the parametry, maybe to the lymph nodes, right? Para-aortics, pelvic lymph nodes, right? So those would mean stage 3. Of course, you have to differentiate. There is pelvic lymph nodes, para-aortic lymph nodes, vagina, right? So all that would mean what? Stage 3 disease. Okay, and of course, stage stage 4 would mean, right, what? Spread to the bladder and spread to the rectum, and of course, distant metastasis. Okay, you all understand? Roughly remember it like this, children. You don't need to know the, 1 is divided again into 2, roughly less than 50% of myometrial invasion and more than 50% of myometrial invasion. Stage 2 simply means it is invading the cervical stroma. Stage 3 has 1, 2, 3 like that, and it basically talks about invasion into the serosal surface of the uterus, going on to the adnexa, then spreading onto the vagina, involvement of the pelvic lymph nodes, para-aortic lymph nodes. Do you all understand? So basically, it spread beyond the uterine corpus, okay, beyond the cervix and all. Do you all understand? Then stage 4, of course, means bladder and bowel and distance metastasis. Got it? So you don't really need to know the very small details of it, right? So that is, so obviously what you have to understand is stage 4 is the survival rate, 5-year survival rate is about 20. Stage 1, the survival rate is 5 years is about 85 or 90. 65, I think stage 3, I can remember, I think 45 or so overall, if you look at it. You all understand? So worse the prognosis when the stage is higher. Okay. What is the second factor that influences? Of course, age and time, right? If the age is far more, right, and then of course the prognosis is worse. Then what is very important is the type. Overall endometrioid type 1s have a better prognosis than type 2, which are non-endometrioid. Okay, these are clear cells, squamous, serous papillary, right, mucinous, all types of carcinomas can be there, and they are the prognosis is worse, right? Then if there is lymphovascular invasion, right, in the histology, when you look at the histology, if there's lymphovascular invasion, that is the tumor cells have gone into the lymph, right, the vessels of the lymph, right, and that can be seen at histology, then the prognosis becomes a bit more worse, right? Then the tumor grading, right? You grade the tumors histologically. It all depends on how the cells are, how the nuclei they are, right? And how they are grouped together, and what types of, how many cells in the histology has a lot of changes, right? So you don't really need to know the specifics, but they are normally graded into grade 1, grade 2, grade 3. So basically, it says different types. You don't need to really know what that means, right? It's a histological grading. The higher the grading, the worse the prognosis. Okay. Next is, in the histological specimen, if adjacent non-malignant tissue, right, has hyperplasia, okay, then the prognosis is worse than when adjacent myometrial tissue has no hyperplasia. So that is something that we need to understand. Okay, right. So mainly 4 things, children. What? Stage, histological grading, okay. Third, type, histological subtype, right? And of course, the lymphovascular invasion. Those are the 4 things that is very important to talk about the prognosis. This is slightly above you all, right, at the MBBS level, but I just wanted you all to understand that you cannot just look at an endometrial or any type of tumor for that and just say offhand, okay, everything depends on the stage. You all understand? So it is not only staging that is important, because sometimes at MBBS level, people think, okay, stage 1, stage 2, stage 3, stage 4, and then you think of the prognosis depending on that and the 5 years level. No, lots and lots of factors come in to decide what is going to happen to the woman in the future. Okay, and the 4 main ones are, remember, stage 1, staging, right? That is the actual physical spread of the disease. Okay, then the grading, which the histology will look at the cells, its nuclear ATPR, the changes inside and everything, and then grade the disease. The third is lymphovascular invasion, whether it's present or not, right? And the 4th, what did I say? The histological subtype. Obviously, that means what? Whether it's endometrioid or clear cell or whatever. Do you understand? So all this will influence the prognosis, and plus all this individually will be taken into account by the oncologist, right? After surgery, if necessary, because sometimes stage 3 and 4 might, there may not be surgery. It may be other types of like chemotherapy and radiotherapy. All these factors will be taken into consideration when therapy or treatment is considered for this particular, right? So only by these, right, can the person taking care of the woman decide what needs to be done, whether it is surgery, whether it is chemotherapy, whether it is radiation, whether it is this first and surgery later, whether it's adjuvant therapy. All this will be decided on all these factors, right? Is that clear? Now, what is important is, now when we have all these, to decide exactly what needs to be done as to what treatment that needs to be given to this woman is decided on our understanding of what the woman has before we start treatment. Okay? You all understand? If we can have an understanding of the staging of the disease, if we can have an understanding of the histological subtype, if we can maybe have an understanding of the lymphovascular invasion, right? If maybe we can have an understanding of the grading of the disease, okay, that will give us a very good idea as to exactly how to treat the woman, dependent on all the information we have, right, about the treatment of this woman. Is that clear? So now to find this out, before we start off, what do? We do the investigations that will give us all this information, or most of the information that we require, right? And how do we get this information? Number one, the histological subtype. How do we get that information? We have to do a biopsy of the endometrial carcinoma, right? And how do we do the biopsy? We can either do a prepare, right? We can either, the best form of doing that would be what? A hysteroscopy and a directed biopsy. Because a hysteroscopy and a directed biopsy, a proper hysteroscopy and directed biopsy will give us, can catch 95% of the pathologies that are inside the uterus, as opposed to other things, right? So it remains the gold standard where we go in and we can really take a good biopsy through our hysteroscope, right? And then, and we can really look at the exact problem and take it out, right? For example, recently I had a patient who I did a hysteroscopy, and there were 3 small abnormal areas that look really abnormal, right? Rest of the endometrium looked atrophic, but here there are 3 sort of like small mountains with yellow things on top, right? So I took 3 biopsies from there, okay? And then afterwards, I did a curettage as well. So there's quite a lot of specimen for curettage, while there were 3 small biopsies from these 3 areas. Now in all that specimen of the curettage, which is basically a dilatation and curettage if you look at it, right? There was only hyperplasia, simple hyperplasia, okay? While in those 3 biopsies which I took, one of them showed atypia, okay? So if I had just gone ahead with the dilatation and curettage, then I would have got it as hyperplasia, simple hyperplasia. And what is our management option for simple hyperplasia? Because only a very small amount of them, about 1 to 2%, will progress towards an endometrial carcinoma, right? While simple hyperplasia or hyperplasia with atypia, 25 to 82% will progress into endometrial carcinoma. And at the same time, if you have atypia, there is a possibility that there is coexistent endometrial carcinoma as well. You all understand? So for the biopsy, it is the gold standard still remains, if you are suspecting an endometrial carcinoma, to get a hysteroscopy and a directed biopsy. Okay? What does this give? If we, in the biopsy, I'm not talking about ATP, okay? In the biopsy, if we get endometrial carcinoma, that will also give us what? That will also give us the histological subtype. So one piece of information which is very important is for us to get the histological subtype, and that is done by taking a sample. And what are the ways in which we take samples? Number one, pipette is a possibility. Pipette is good when there is a uniform enlargement of the endometrium and there is estrogenized sort of thickened endometrium. Yes, you can get it. But remember, type 2 ones are what? They come with the atrophic endometrium. Sometimes you might not be able to get a proper biopsy with them. So basically, a pipette is one way which you can get, right? Pipette is what? It's a vacuum aspiration. You put in a small tube, create a vacuum by pulling the plunger, then there's a vacuum, but there are a few holes in there, and then you, with the created vacuum inside, so basically you have a vacuum tube inside with holes in it, right? And then you just go up and down, then everything will be sucked into the tube, and then you take it out and send it. It gives a good biopsy. Okay, so it will sample quite a lot of the endometrial cavities. That is one option. Then there are other ones like Vabra, Novak Curat, where it's slightly larger ones which you can put inside and do a suction vacuum aspiration of it, right? But the best one, children, is what? To do a hysteroscopy and a directed biopsy. Of these, office hysteroscopies or very small outpatient hysteroscopies may not really give us a good sample because we cannot take a good sample with the normal outpatient hysteroscope. So the best form to take a biopsy, if you really suspect, would be a normal formal hysteroscopy and a directed biopsy. Is that clear, children? And what does that give us? It also gives us the tumor grading as well from the histology. So they will give us the tumor grade as well, whether it's tumor grade 1, grade 2, grade 3. So basically from these biopsies, we get two pieces of information. One is the grading, right? Remember, I told you it has a bearing on the treatment and the prognosis. And the second is the histological subtype. Is that clear? Next, the staging. Now, what does basically staging means? How much it has spread, okay? And where it has gone, right? So the best form of staging usually is a MRI with special ones. It'll give us it'll give us the amount of muscular invasion, right? It'll give us up to what extent it has invaded. It'll give us, tell us whether the stroma is invaded. It will tell us whether the top of the vagina is invaded, whether it has invaded the bowel, the rectum, right? The serosa, the adnexa, and distant abdomen. And it also will give us an idea of the pelvic and the paraortic lymph nodes, right? So if we do an MRI pelvis and the abdomen, it covers almost everything. Got it? However, the first thing which we do is a transvaginal scan. The transvaginal scan will give us the thickness of the endometrium and the invasion into the myometrium, whether it's less than 50% or none. And it is also very, very sensitive, but probably the MRI is more sensitive. A CT can look at, computer tomography can look at the lymph nodes of the paraortic, but it is not very good at looking at invasion of the myometrium and the adjacent soft tissues, right? For that, we need to perform a MRI. So basically, to look at the stage, the best form would probably be a MRI, right? CT can we can look at the lymph nodes, and if the MRI is not available, you can, instead of that, we can do a CT, but if the MRI is available, that's better. And of course, as I told you, the ultrasound scan also will just give us quite a lot of information about the depth of myometrial invasion, right? Remember, the stage 1 is has less than 50% and more than 50%, right? That MRI can give very well, and also the transvaginal scan also can give us. So these are the investigations that we can perform. Remember, children, I have taught you all one. When we investigate a woman, we do it in two ways. What are these? One pathway is we try to diagnose and stage whatever disease is there by doing investigations. Okay. The other one is we are looking or checking to see whether this woman is fit for surgical or whatever intervention that we are planning to do. You all understand? So these are the two reasons that we do investigations. One is to diagnose the disease. The other is to test whether the woman is fit enough to undergo treatment, whatever treatment we are contemplating. Is that clear? Right? So to diagnose, stage, find out the disease, these are the ones which we do, right, for suspected endometrial carcinoma. Okay. Now, let's go, because I have been talking from staging, right, and the prognosis to the investigation. So now we'll go the other way around. Okay. What I want you to do is to understand what we are talking about actually. Now, so remember the staging of the disease or how bad it is always surgico-pathological. You combine the surgery, right? And the final would be surgical, and then of course the pathological findings will tell us exactly, the histopathology will tell us exactly what the disease is by putting both together. Got it? Right. Now, how do these women present? Number one, the commonest presentation after menopause is postmenopausal bleeding. Okay. Postmenopausal bleeding in a woman. And what does postmenopausal mean? There has been a cessation of her period for 1 year. And then she presents with bleeding. Right? So the commonest presentation postmenopausal, one of the presentation postmenopausal bleeding. Right? That is after menopause. Other women will present with abnormal uterine bleeding. Okay. So other women will present with abnormal uterine bleeding. So this may be, women less than 40, I told you, 45, really present with other types like type 2 cancers, right? May not have attained, okay, but then they have irregular bleeding. Remember, cancers generally do not bleed regularly, which means they bleed for the period, heavy bleeding, and then doesn't bleed at all, then heavy bleeding, doesn't bleed at all. They don't do that. You will have irregular bleeding. Okay. So not confined to the period, the menses zone, right? However, if there's a lot of heavy bleeding, right, you might, or if the menses is prolonged, you might want to suspect and take an endometrial biopsy. Okay. And women who are having no menopause, but they continue to bleed until about 55, 56 years of age, in those women also you might need to suspect endometrial carcinoma as well. Okay. So any irregular bleeding, usually after 40 years of age, right, abnormal uterine bleeding, requires an endometrial biopsy, right? So 40 seems to be the cutoff mark, because less than 40, the chances of having endometrial malignancy is rare, 1 or 2%, unless otherwise it is a family. Okay. But most of the women will be over 40. So therefore, over 40 years of age, it is reasonable for us to take an endometrial biopsy in any way, maybe a PPL, maybe a QCharge, anyway, to diagnose a pathology. Is that clear, children? Right? So that is number 1. So they present with postmenopausal bleeding, right? Otherwise, it's irregular. Of course, they can present with advanced stage disease, which is rare. Okay, they can have all the advanced stage of disease because of the metastasis. If there is mets in the lungs, then they will have shortness of breath and hemostasis. If there are mets in the kidney, they might have blood in the urine. If there are mets in the bladder, there will be hematuria, right? If there are mets in the bone, they will have severe bone pain and fractures. If they have mets in the liver, they will have jaundice, right? Because there will be liver enzymes will be out. Okay. If they have mets in the small bowel, they will have small bowel obstruction. Okay. If they have mets in the skin, right, they will have skin lesions, right? If it has spread to the pelvic side walls and involve the ureters, they will have severe backache due to hydroureter hydronephrosis. Okay. If they have gone into the nerves, they will have different kinds of severe pain depending on the nerve that is involved. You understand? So that they might present that way, but I'm talking about not those. But you have to keep in mind, if a woman really presents in these stages with metastasis, they might have all these presenting symptoms in your clinical presentation. Is that clear, children? Right. But the commonest which they play is either postmenopausal bleeding. If there's postmenopausal bleeding, 10% of these women will have endometrial cancer. Okay. However, after 40 years of age, the age group for endometrial cancer up to 40 to 55, these are not menopausal women. Okay. And these will have the presentation with abnormal uterine bleeding. Is that clear, children? Then we come to postmenopausal women, a special period, right? And if these women are postmenopausal, the best form of triage, only postmenopausal women, children, the best way to find out whether this woman is having endometrial carcinoma or to triage is a transvaginal ultrasound scan. I'm not talking about perimenopausal women. Okay? You all understand? Perimenopausal women will present with different kinds of bleeding or metastasis. Postmenopausal women, when they present with postmenopausal bleeding, 10% of the women will have endometrial carcinoma. And the best way to triage these women is to do a transvaginal scan. In the transvaginal scan, it has been found if the endometrial thickness is less than or more than 5 millimeters, she needs to go for an endometrial biopsy. Okay? Less than 5 millimeters, or some take the cutoff as 4 millimeters, it's highly unlikely that it is endometrial carcinoma. Right? However, remember, there is a possibility there may be. So if it's less than 5 in postmenopausal one, if the thickness of the inside is less than 5 millimeters, in some it is 4 millimeters, then it's highly unlikely. So they can be reassured and sent home necessary. However, if it continues, then you might need to do an endometrial biopsy. The second warning sign is what? If there's fluid inside the endometrial cavity, they require an endometrial biopsy because there's no reason why they should be producing fluid. And the third thing that they go for an endometrial biopsy, if there's an irregular endometrium. If the endometrium is very thin and fine with no irregularities, then they are screen negative. We don't need to do anything. So 3 things you have to remember, children, right? If in postmenopausal women, if there's fluid inside the cavity, if there's an irregular endometrium, right? Irregular contours or polyps or whatever, right? They need biopsy or hysteroscopy and biopsy. And the third is a thickened endometrium more than 5 millimeters, they need a biopsy. You all understand? So the transvaginal scan is very important as a tool to find out initially whether there is a suspicion for endometrial carcinoma for postmenopausal. Okay? Perimenopausal woman, yes, the transvaginal scan is an important tool, but thickness alone is not important in perimenopausal women because there is no cutoff mark. But however, if you find an irregular endometrium, or you found cystic and solid areas inside, right? Those will cause us to be suspicious And of course, then next time is if you find myometrial invasion and different things are, then of course you need to go ahead and do the rest of the investigations, right? So that is what you have to remember about the postmenopausal women and the use of the transvaginal ultrasound scan for screening. It is so effective that you can, in a postmenopausal clinic or postmenopausal bleeding clinic dedicated, if a postmenopausal woman comes and she's bleeding, you can send her to the clinic, they do a transvaginal scan, and if it is not suspicious, then she's sent home. You'll understand the trial. The chance of her having endometrial carcinoma, if the endometrium is very thin, is very, very small. Got it? This is not true for perimenopausal women children. Don't mix those two. Okay? There is no cutoff mark for endometrial thickness in perimenopausal women. That is women who are already still menstruating. Okay? It's only for postmenopausal women. Right? So these are the investigations and the way in which we look at bleeding, and this is the way we need to diagnose. Once we have got the histology, then of course I remember I told you that we need to stage the disease, grade the disease, and arrive at a conclusion as to exactly where it is, right, and what it is, and what organs are involved, and then you decide on the treatment. Is that clear so far? Any questions that you want to ask me? Okay, few questions. Is DNC only diagnostic or can it be therapeutic method? DNC is considered to be diagnostic, right? So the sole intention or the purpose is to get a biopsy. DNC is not considered ideal, and actually in other countries it is discouraged. You don't do DNCs now in other countries, but however we do it, because if the hysteroscope is not available, then we do go for a dilatation fluid count. But it is not recommended as a method in most countries. If there is an indication for dilatation fluid count, then it's better to go for a hysteroscopy and a biopsy. What's the device we use to do dilatation? Okay, those are called Hay-Gas dilators. Okay, so these are metal rods which are slightly curved, and they come in increasing sizes, right? So you put the smallest in, right? First do a vaginal examination, find out which direction the womb is. You put the dilate in, and then first you sound the uterus, and then you know exactly the length of the uterus, and therefore you hold the sound so that it is shorter than the total length of the uterus, and then you put it in so that your fingers are guarding and preventing it from going further and perforating the uterus. Then with each gradual size, you dilate until the size is reached where you can put in a uterine curate, right? So when the uterine curate can be put in, then you do the dilate. So a curettage, you have to, if you are doing a curettage, which is the old-fashioned method, then of course you have to do the anterior wall, the side walls, the posterior walls, the fundus, and the upper walls to take the curatives. Okay. So the device is called the Hay-Gas dilatation. During the perimenopausal period, they have abnormal uterine bleeding due to HPO dysfunction. Does that require a biopsy? Any abnormal uterine bleeding will require a biopsy after 40 years of age, right? Hypothalamic pituitary ovarian axis dysfunction is a diagnosis that comes later, but initially, even due to, if there's hyperestrogenism due to HPO dysfunction, then of course the uterus might be having an abnormal endometrium, which we need to treat. So yes, definitely we need to do a biopsy, right? Okay, so biopsies can come as different ones. Okay, they can come as endometrial carcinoma. They can give you the histological subtype, or they can have normal ones, just proliferative endometrium, then secretory endometrium. They can have hyperplasia with atypia and hyperplasia without atypia, right? And then they can have endometrial carcinoma. In the pre-malignant diseases, I was discussed what we do with hyperplasia with atypia and what we do with hyperplasia without atypia. Those are conditions that come before, or these are pre-malignant conditions, right? Which you think. So now we are talking about endometrial carcinoma, right? Okay. So now we have discussed to summarize what it means, what are the risk factors which we have discussed. Okay. We have discussed how what are the factors affecting the outcome, okay, which are surgical and surgical pathological. Okay, I've discussed those, and then I have told you how to investigate this disease so that we get the information which we require to treat the disease. Okay, and I have spoken specially about postmenopausal women and what are the investigations, how a transvaginal scan is used as a tool to triage these women, right, to find out whether they have endometrial carcinoma, right? And I've told you about the difference between perimenopausal and postmenopausal. Remember, there are no cutoff marks in the perimenopausal, but there are cutoff marks in the endometrium for postmenopausal women. Is that clear? Right? So this is what we have discussed so far. And I have roughly spoken to you about the stages. Stage 1, stage 2, stage 3, stage 4. This is the spread of the disease. I have spoken to you about the possible survival rates. And of course, not only staging, but there are so many prognostic factors to think about or associated factors that will have an influence on the prognosis and the outcome of the disease. That will include age, comorbidities, weight, surgical expertise available, right? Then the staging, subtype, everything will come into play when you think about what's going to happen to you. Is that clear, children? Right. So now let's get on to treatment. In early stage disease, in stage 1 and 2, right? The mainstay of disease is surgery, especially in the early stages. The best form of treatment, if there is no spread, especially to the cervical body, okay, stage 2, the first stage, the best form of treatment is hysterectomy, right? And of these two, in the early stages, the best form is laparoscopic hysterectomy, which is total laparoscopic hysterectomy, combined with bilateral salpingo-oophorectomy, okay? Combined, so it's total laparoscopic hysterectomy or abdominal hysterectomy, so you can do that as well. Hysterectomy with a bilateral salpingo-oophorectomy. This is the standard treatment for early stage disease. Okay. Now, as grading increases, as if it goes on to the cervix, when there's invasion of the cervix, then it becomes a bit like cervical carcinoma. You don't understand? So therefore, when the cervical stroma is involved, and if it spreads even to the upper part of the vagina, right, then that is stage 2, and then stage 3 also beginning, okay? Then if we are going to go ahead with surgery, then you are looking at radical hysterectomies, okay? And the treatment is a bit like cervical carcinoma, right? So therefore, the name, of course, Wertheim's will come into play, but it is not basically Wertheim's, right? So it's classified depending on the stage of the disease and the spread by MRI and everything, right? But therefore, remember, it is just not a pure hysterectomy, bilateral salpingo-oophorectomy only, okay? There are sometimes if it goes to the cervix, then it becomes a radical hysterectomy type surgery. And the extent of the radical hysterectomy will change depending on the increase in stage and the histological subtype. Got it? In addition to this, what are the other things that can be removed or combined with, depending on the stage and the histological subtype? You can add pelvic lymphadenectomy and para-aortic lymphadenectomy, and you can add an omentectomy, and also at the same time, of course, you can do peritoneal washings to add to these or get a complete understanding of what is happening. You all understand? So doing a pelvic lymphadenectomy at what and when, there are controversies. Okay, whether pelvic lymphadenectomy needs to be done or not, there are some controversies. At what stage they need to be done, whether they contribute towards a better outcome or not, it's a bit of a controversy. Because the pelvic lymph nodes also can be, we can treat them with radiotherapy. And these lymph nodes can be targeted. The para-aortics also can be treated with radiotherapy. So whether to do in different stages pelvic lymphadenectomy or para-aortic lymphadenectomy, whether it is an addition, how good it is still not an entirely resolved problem. You all understand? So if you ask for a standard treatment for early stage endometrial carcinoma, the standard treatment is hysterectomy, bilateral salpingo-oophorectomy, salpingo-oophorectomy. Additionally, pelvic lymphadenectomy, para-aortic lymphadenectomy, omentectomy, and peritoneal washings can be taken. And that, of course, will help in the surgical staging. Okay. However, so say surgical staging means, okay, they will cut it open. Okay, they say, okay, the uterus has this, that. Then, okay, this pelvic lymph nodes also has this metastasis, cancer cells, and the para-aortic also has, if you have done a clearance of all those. But however, that does not necessarily, although surgical staging, we have got a perfect sort of surgical staging, that does not necessarily increase the outcome and the prognosis of woman, because the para-aortics and the pelvics can also be treated by radiotherapy. And if the para-aortics and pelvic lymph nodes are positive, the woman will anyway need radiotherapy. Do you all understand? So that is why there is a controversy. Okay, because from what you get when you have a total uterus out, right, with the bilateral salpingo-oophorectomy, then the histopathologist will tell us the subtype and the grading of the tumor. And they will also talk about lymphovascular invasion and what has happened to the adjacent myometric tissue. Dependent on that, we can postulate whether the lymph nodes are involved or not. And dependent on that histological findings, we will decide on radiotherapy and maybe chemotherapy at a later stage. Do you all understand? So anyway, the woman will get radiotherapy depending on the histological subtypes and the lymphovascular invasion and so on and so forth, only from those specimens. So therefore, that is why there's a controversy that exists as to whether the pelvic lymph nodes and the para-aortics needs to be cleared, right? So depending on the expertise and the centers, different approaches may be there. But remember, for you all, you have to understand that these approaches may change. So definitely 100% hysterectomy, whether it's laparoscopic or open, right? Doesn't matter. Hysterectomy and bilateral salpingo-oophorectomy. Additives, or just depending on the stage, it might be pelvic lymphadenectomy, para-aortic lymphadenectomy, and omentectomy and peritoneal washing. If you know that, that is more than enough. Is that clear? Then comes in more advanced stages, right? In more advanced stages, right? If it's cervix, if the cervix is involved, we are looking at a radical hysterectomy as well. Then, of course, radical hysterectomy itself, definitely pelvic lymphadenectomy is going to be performed. You understand? So if the cervix is involved, we are looking at pelvic lymphadenectomy as well. And there's a possibility they might do para-aortic because it seems that the involvement is higher. So therefore, it becomes a debulking procedure, right? You get more tumor out, it increases the prognosis, right? And then as stage advances, then you add on different types. And one is radiotherapy. For you all, what you have to understand is, it is external beam radiation, which is given over the tummy into the pelvis. That is one way. And the other is called brachytherapy. Brachytherapy is the probe is put into the vagina and the pelvis is irradiated through the vagina. Overall, brachytherapy has been found to be more effective for the treatment of pelvic lymph nodes, right, than external beam radiation. Is that clear, children? So therefore, brachytherapy is more effective in this. Then comes, if for stages that are beyond that, right, then comes what? Chemotherapy, right? So sometimes it might be adjuvant, you do surgery and then you give adjuvant radiotherapy depending on the histological subtype. That is decided by the oncologist. Then there is chemotherapy. In stages later and there are distant metastases, right, where surgery is not possible, then chemotherapy may be an option. And chemotherapy is normally based on platinum-based, which are paclitaxel, which is we have cisplatin, right? There are normally 3 are combined together, right? And doxorubicin, right? Those are the 3 things that. So if you just know paclitaxel, if you know cisplatin and doxorubicin, those are the common chemotherapeutic agents that can be given for this condition, and there is more than enough for you. Remember, sometimes it may be decided first to give chemotherapy, shrink the tumors, and then adjuvant surgery may be a possibility for debulking. Okay. Sometimes radiotherapy, then surgery becomes an adjuvant, but those are very complex cases. So depending on the patient to patient basis. For you all at MBBS, remember, advanced stages may require radiotherapy and children chemotherapy. For radiotherapy, there are 2 basically, external beam and brachytherapy. Of those, brachytherapy is more effective in getting at the lymph nodes, right? However, they can, all these external radiation can cause, the commonest problem they cause is problems with diarrhea, right? And colitis, because the rectal mucosa and the bladder mucosa both can get involved in this, right? And therefore, it destroys and changes the mucosa, and that causes a lot of problems and side effects, right? Of course, if you do lymphadenectomies, that can cause lymph to collect in the legs, and the legs can become very large as well, right? Lymphocysts can form. So these are the problems. Chemotherapy, of course, it's a very difficult thing. You know, the hair will fall off, they will have skin discoloration, they will have very, very difficult time, right? So chemotherapy seems to be the last resort, right? So those are overall, these are the things as MBBS students that you need to know about endometrial carcinoma, right? So there's nothing else that you really need to do. Okay, so I really need to know, right? So if you look at now, read your books, you will get a general idea. And so to reinforce what I told you, children, please go back and read about endometrial carcinoma. Look at the stages. Since I have given you an overall sort of understanding of the whole thing, now it should stick in your mind, and this you can use this for your, you know, when you are writing your. And if you write this about endometrial carcinoma, you'll get a almost completely all the marks. Okay, right? Okay, there is a question which I will answer. Why do we combine hysterectomy with bilateral salpingo-oophorectomy? The reason, children, is that, as I told you, remember, the lymphovascular invasions and the vessels are interconnected with the fallopian tube and the ovary. See, the ovary has a blood supply from the aorta, and then through the ovarian ligament, right? They connect with the uterus, and the other way around as well. So therefore, there is a possibility there may be metastasis in the ovary as well, micrometastasis. So therefore, we always combine it with the bilateral salpingo-oophorectomy. Okay. One thing which I forgot to tell you all is fertility preservation. What is the place of progesterone in endometrial carcinoma? Which means, if a woman has endometrial carcinoma, is progesterone, is it possible to give high dose of progesterone and cure the disease? The answer is no. Okay. For the moment, we do not use high-dose progesterogens to treat endometrial carcinoma without a surgical implant. However, progesterone, what are the types of progesterone? There are different kinds. Medroxyprogesterone is there, right? There are different kinds of progesterone that can be used. Progesterones can be used in palliative therapy. Okay, palliation. When the metastasis is there and it is a progesterone is useful in palliative therapy to reduce the symptomatology of the woman. The progesterone is used. But as a primary thing to treat endometrial carcinoma, no. However, if the woman wants fertility still, right? Progesterone or high-dose progesterones initially may be an option, but it needs very, very careful follow-up. And then finally, if she wants fertility, then she can try for it. And after that, probably it's better to remove the uterus afterwards. So progesterone therapy, high-dose progesterones are only used very, very, very rarely if the woman wants fertility. And depending on the, usually it is endometrioid type, which is more susceptible to progesterone therapy. And the next type is used are in palliative care, where there's nothing else to give, and then there's a problem with metastasis, other or ignorant. Progesterone can give some form of release to women. And of course, all the rest of the palliative care will come into play. And that is something that you have to understand. The other last thing which I should have told you about is recurrence. If there is recurring disease in the pelvis, then you can, more radical surgeries can be done for recurrent disease. And for recurrent disease, and if it spreads so far, progesterone therapy also becomes an option. And of course, for recurrence, chemotherapy also is an option. Radiotherapy is also an option. You all understand? The specifics you all don't really need to understand, but if you know these understanding, like recurrence is possibility, progesterone therapy is possibility, what chemotherapy means, right? What radiotherapy means, right? So those are more than enough for you to go at this level. Okay. So that is basically all that I wanted to teach all about endometrial carcinoma. Okay. Right. So since there are no questions, right? So then we'll wrap up the session. I want you all to type in the topics you want to cover in the next week's session, the obstetric topic which you want me to cover. Okay. So send me a few suggestions, then I will choose something from that. Okay. Okay then. Good night.
Good night, sir. Thank you.
Good night, sir. Thank you so much,
Thank
sir.
you, sir.
Thank you, sir.